get the meeting started. It's wonderful to just see the names pop up and to talk to some of you as you came in this morning. This is our first meeting for the year, a very delayed start for many reasons, but we hope a start that gets us back on track soon enough. I know this is not our usual time. Our usual time is the second Wednesday and the last Friday of the month. We will try to stick to those times, but sometimes things happen like today where we have special guests in town and we like to take advantage of learning from their expertise. And so just to remind you, our meeting that was scheduled on Wednesday, we had to postpone it. It will happen on the coming Wednesday, the 15th. Our speaker unfortunately was unwell and we felt that getting him back to his 100% level of health was more important. So we will be having that meeting from the pharmacy next Wednesday. And then Dr. Jessica Edwards is already in the meeting, and Dr. Jessica Edwards has prepared a PAHO meeting for us at the end of the month, which will be the last Friday, Friday the 31st of March. I may have gotten the date incorrect. I'll let you know before we sign off, but we will tell you about that meeting at the end of this one because we will need for you to pre-register for her meeting, Dr. Jessica Edwards meeting. Actually, sorry, my apologies, Wednesday, March the 29th. And it's One Health Approach to Antimicrobial Resistance. It's a webinar for human, environmental, and agricultural health professionals. And it's being put on by PAHO, and we would need you to pre-register. So we will start sending that information out at the end of today's meeting. So good morning again,
Can I call you
everyone.
back? I'm just starting the Zoom CME for 8 o'clock.
Okay, so Dr. Mitchell, we are hearing your conversation. So can you please mute for us, Dr. Johnson? Can you please mute for us? We are hearing your conversations. Okay. So without further ado, we are going to start today's meeting. And Dr. Mitchell, when you come on, you can lead us in a word of prayer before we start the meeting. But Dr. Mitchell is going to be chairing this morning's meeting. Dr. Monique Mitchell is no stranger to most of us, and especially to you physicians in public health. She is a podiatrist. And Dr. Mitchell, when you come on, can you please let our physician community and those in the meeting know a little bit more about you, what you do, how long you've been doing it, and where they could find you? Thank you very much, and welcome, Dr. Mitchell. And you can start us off with a word of prayer.
Okay, no problem. Thank you, Dr. Black, for having us. And we begin with a word of prayer. Let us pray. Gracious and loving Heavenly Father, thank you so much for sparing our lives to see another beautiful day. Thank you for the opportunities that you provided for us, for the opportunities that we may be co-partners with you in the ministry of care and health of our people. We thank you, O Lord, for your many guidance, your blessings, and the many ways that you have protected and guided us throughout our lives. We thank you for the opportunity that you've given us to care for others and help us always to focus on the fact that that is a special privilege for us. We ask that you be with us in this meeting today. We may learn and have an open mind to be able to implement all that we learn here today. We ask that you bless the speakers and all the participants. In your holy name I pray. Amen. All right, so we're going to get started. And today I just want to welcome everybody here who is here. I see a lot of persons from different backgrounds and different persons who are here, and we're very pleased that you are here. We especially want to welcome our guest, our special guest, Dr. Shanika Hill and Cherison Cuffey, who are both from Barry University, and you'll hear a little bit more about them later. I'll tell you a little bit more about myself. Like Dr. Black said, I am a podiatrist, and I have a long history in health, actually. I was a registered nurse for a lot of years, and then I went on to do master's in public health, and then I also went back to do podiatry, which I completed 15 years ago. I can't believe it. And so I've been home for 15 years now, practicing mostly in private practice, a little bit in public health, but I currently work at the Ministry of Health and also in private practice at Bahamas Surgical Associate Center. You'll be hearing a little bit more about that as well. I can be reached. I'll actually give you my cell phone number, 376-2395 is the easiest way to get me by WhatsApp or by calling that number. So, and then of course you can call me at the office as well, 603-1814. I'll repeat the phone number, 376-2395. Okay, so let's get started because we have a lot to cover and we want to be on time today. So we're gonna begin this morning. Our topic is a multidisciplinary team approach to diabetic foot management. And we hope that that is an area that we as podiatrists are very intimately involved in and promote vigorously. And we want to encourage you as well to see that as the way forward as we continue in this battle to save the diabetic foot. So to begin us off, we're going to start with Dr. Johnson. He's going to give us an introduction, I guess, to the topic, hair in the Bahamas and the importance, why we need to focus on a multidisciplinary approach and why we need to not do it the way we've done it before. Okay. Somebody needs to mute their mic. I can't see who it is.
Yeah, I'm trying to identify who it might be myself. Can everyone please check that their mics are muted? Okay, go ahead, Dr. Mitchell.
All right, go ahead.
Johnson, sorry, Dr. Danny Johnson, your mic is still open.
He's going to speak now.
Okay,
so go ahead, Dr. Johnson, and give us an introduction at this time.
Thank you very much. Good morning, everyone. I'll be swift so we can get to the heart of the matter. Very simple. I want to thank everyone involved here. We're looking for the output of this brief meeting this morning for collaboration and cooperation. Why? A National Diabetes Federation says that every 20 seconds, an amputation occurs globally. And unfortunately, it's a death sentence for the patient. The real tragedy is that this is avoidable. The definition of public health is the prevention and control of disease and its clinical sequelae, its complications. This week, we answered a clarion call in the Bahamas about the diabetic foot and foot health. And in 1 week, we went out and did about 500 patients seen and treated, and maybe about 100 procedures. It demonstrates the need for these interventions across this nation, but even across the region, which has one of the largest rates of amputation per capita in the world. We want to say the need for this multidisciplinary approach is twofold. First part, and those of you all who know me, and most do, some don't. I hear some young doctors in the hospital trash talking us sometimes. You got to get to know us. Is that I'm an Army trained surgeon. I was in the Army in North Africa, and then I worked in the US Navy. And this is a tragedy. The diabetic foot is a clinical and surgical emergency. You don't want to go it alone. If you do, it is horrific for you and the person. Second part is the results are much better if you have collaboration and cooperation. So it's for you and for the patient. That's the simple reason why you have to have this approach. Later today, we're going to meet with the Minister of Health, and I will ask him again, and maybe for the last damn time too, to have a diabetic foot clinic in the Bahamas. A third of our surgical wards are packed with these people. They are the longest stay with the worst result. You don't want to leave it like that. You got to change. And so today I thank Dr. Hill, this is the Barry University intervention, 1 week of their time. The doctors involved, Dr. Mitchell, Dr. Horsley, Dr. Pinder, Dr. Lopez, Dr. Cuffey, Dr. Londorno, Dr. Baker, and Yanka for her great organizational skills, and the, 20, 25 medical students who came along. to break the cycle of every 20 seconds, someone having an amputation. Why? When I first started 30 years ago, it was every 60 seconds this happened, right? A couple of years ago, I went to a meeting in The Hague in the Netherlands. It was the epidemic of the third world then. It was every 30 seconds. And now it's every 20 seconds. This can be done. There is good news. I think we demonstrated this week how it is done. I want to lastly say, we want to thank everyone for their kindness and commitment. These students, we took them to Abaco on Wednesday. We did Cooperstown in the north, Marsh Harbor in the middle, and Sandy Point in the south. I put about, 8 or 10 of them on the back of a pickup truck. We drove from Marsh Harbor to Sandy Point. That is an hour and a bit drive. And it rained along the way. They're on the back of a truck, a pickup truck. We got there, they hopped off the truck in front of the little clinic. There were 45 people waiting and another 10 who just turned up, I guess. Those kids hopped off that truck, brushed off, took a picture, went inside without saying a word, got to work, knocked out all of those patients, had lunch, and coming back, I called. I said, look, if people send me a van or something covered. And they hopped back on the truck and came back. Didn't say a word. And actually, when we got back, said, boy, that lunch was fantastic. And thank you for letting us help these people. That's my message to you all, right? This country is no reason that we cannot have a leading institution that attack this problem. It'll be fantastic. And thank you for letting us help these people. Thank you very much. God bless.
Awesome introduction, Dr. Johnson. And yes, I agree completely. The ingenuity and the spirit of these young people are just fantastic. And I hope that in our experience and in their interaction with us, that will encourage us also to have that attitude and that spirit as well. So we're going to move on to our first speaker, who is Dr. Shanika Hill. She is a podiatrist as well, and she is the clinical dean at Barry University, and she is responsible for all the students and actually for planning this whole mission trip to the Bahamas for us the second time. Like Dr. Black said earlier, they were here in early 2020, just before COVID. And so we're very pleased that they're here again. And her team is actually 24 persons, 4 podiatrists and 2 logistics persons and 18 students. So they were very eager to come, and she actually had to turn away some people because there were no more spaces. So we're hoping that, well, we know they're tired, but they're enjoying themselves. And we're very pleased to welcome Dr. Shanika Hill, who will talk to us and actually present a case study that we did this week on the multidisciplinary team approach. Dr. Hill, go ahead.
Good morning, everyone. Thank you so much, Dr. Mitchell, for inviting me, Dr. Johnson, for being with us this week. And I will be brief, Dr. Mitchell, since you only gave me not even 15 minutes. So let's get this party started. Okay, let me go ahead and share my screen. Can you all see my screen okay?
Yes, we can.
Perfect. All right. So title of my talk this morning is going to be Multidisciplinary Approach to Diabetic Foot Ulcerations, a case study. And as Dr. Mitchell said, I'm the Associate Dean of Clinical Education. So I might ask you some questions. In my line of work, I do a lot of education. So I want to make sure that the group that I'm speaking to is learning something as we move along. So we're going to talk a little bit about the patient. We're going to break down of the paradigm in terms of who we call, when we call, and discuss the multidisciplinary approach to healing in a stepwise fashion. So this is our patient. So he's a 72-year-old Black male, history of diabetes, high cholesterol, hypertension. He lives in Eleuthera, and he actually is known to the South Beach Clinic. Dr. Johnson has seen him before. Some of his wound care nurses, his excellent wound care nurses, have seen him before. And he had wounds that they were managing on the left foot. And he came here just for this time to spend with us on the right foot, his wounds. And he was doing some wound care in Eleuthera, and unfortunately, they were not treating the wound correctly. And he came to us with a red, hot, swollen, super malodorous right foot wound. All right, I have here to show the video. Okay. Can you guys see my screen?
Yes, we can see your screen. It
Oh,
just
okay.
says show video.
Okay, yes. Okay, good. All right, I just haven't put it up yet. Okay. Can you still see my screen okay? Resume share. Okay, let's go back.
Yes, we are still seeing your screen.
Okay, I
I'm
apologize.
seeing that I see play on the side of your show video. The video isn't showing yet though, but is this
Okay.
the same video from the test?
It is. Let me stop share and let me try this again.
What to do is do it exactly the way you did it in the test because it worked.
Okay. Okay,
Seeing it.
perfect. All right.
Before picture, and we got so this is the before picture, and we got to take another picture for the after.
So that is it. So you can see that this is actually a patient seen by one of my students. He has an ulceration on the plantar surface of the foot, as well as the dorsal surface of the foot. And he has an ulceration on the remaining third toe. And if you track from plantar to dorsal, these wounds actually coalesce. So we're able to, the whole area is full of pus, it's red, it's swollen, and which is why we chose him to be our case study today. I'm going to go back to my presentation. Okay. All right. Whoa, I don't know what I just did here.
Yeah, you're back on your presentation.
Perfect. Okay. Can you still see it?
It just disappeared and it says loading.
Oh,
Okay, it's here and it's on breakdown of the paradigm, the patient.
okay, perfect. It doesn't appear to, you know what? I might just leave it
It's
this
there.
way.
Go ahead. You can go ahead and continue speaking. The slide is there.
Okay, all right. So the patient, we have to look at the patient's age, which is going to dictate what we do. He's 72 years old. He's from Eleuthera. He's a male who, most men, don't like to go to the doctor very often, but he fortunately understands the importance of foot care. So he has seen folks in Nassau. He does see the wound care nurse in Eleuthera. He's a Black male, and there's all sorts of issues going on there. And his medical history also speaks to us, his long-standing history of diabetes, high cholesterol, and high blood pressure. So first thing we have to do is look at the patient and kind of assess, who he is, how he is, and how we can best assist him. On physical examination, we found that he had faintly palpable pulses to the DP and PT. He is completely insensate, meaning he cannot feel any part of his foot. He has an amputation of the first, the fourth, and the fifth toes. And as we saw, the wound was posterior dorsal. And he had those remaining toes looked like kind of purpley sausages, which is kind of a buzzword that to us speaks to something, possibly an infection in the bone underneath. So all the ulcerations were purulent, malodorous, and the foot was extremely warm to touch. So this is how we start our multidisciplinary approach. So we assess the wounds. So first thing we have to do, the patient is there, he's in our sites. We have to release the pressure of the wound. So we do an IMD or an incision and drainage right bedside, and I'll show you some photos of that. We have to assess the bone and the soft tissue. So do some x-rays, make sure that there's no gas gangrene, which is, the first thing we're thinking about. And then we dress the wound. So first thing is, who is his primary care doctor? Who is he seeing for his diabetes? How controlled is his diabetes? And we have to do some blood work. So we reach out to whoever who's controlling his diabetes. So that's our first folk that we speak to. Second, we have to consult or make sure that we have on board a vascular surgeon, because if the wound is not bleeding, the wound is not going to heal. There has to be blood. So it does not matter what kind of wound care product you put on a patient. If they are not bleeding, it will not heal. So we have to reach out to the local vascular surgeon, or in the States for us, we utilize an interventional radiologist for some of our vascular procedures. Our third person we have to reach out to is our wound care management. We're going to, at this point, consult Dr. Johnson or Dr. Mitchell here locally and utilize a qualified, competent wound care nurse to provide him some care. Or we can, I don't know how it works, but maybe training the nurses over in Eleuthera to make sure that they do a better job at managing his wound care. And finally, we have to consult infectious disease. I don't know if you guys consult the pharmacy or how that works here, but we have to manage his antibiotic regimen, because we are highly suspecting that his osteomyelitis, but at least he has a soft tissue infection. So these are some photos of the wound post-debridement. So what we did, we just opened it up. We flushed, we used a betadine saline mix, and we just slowly pulsed and flush until we released all of the pus in the area. The patient was, again, completely insensate, so we were able to make these large incisions on the plantar and dorsal foot without any type of anesthesia. So these are the orders that we then go ahead and make sure that we get. We wanted a CBC, CMP, A1C, ESR, PT, PTT, INR, wound culture, bone biopsy, X-rays. And these are some of the results. So his ESR was greater than 100. ESR is a non-specific indicator of inflammation, but for us, it has a high correlation with osteomyelitis. In his case, it was greater than 100. So that screams to me, bright red light, that he's possibly has osteomyelitis in at least somewhere in the foot. His A1C is 10.5, which honestly, I've seen higher, but 10.5 is definitely excessive. So he is not well controlled on his diabetes. And his BUN and creat is 10.8, so it is reduced. So when we're considering antibiotic management, we have to make sure that we choose something that's not going to be a kidney killer. And his WBC is 5. And I circle this because I tell my students that diabetes hides the immune response. This is actually a quite normal result with a foot that was red, hot, swollen, purulent. So diabetics that have normal WBCs does not mean that they're not infected, that they do not have osteomyelitis or some significant problem. It just means that their diabetes is doing the best job at hiding their immune response. Diabetics who have WBCs that are significantly greater, 15, 16, 17, 18, those are those diabetics that have gas gangrene, that are probably in some serious trouble because the infection has overwhelmed their ability to be sneaky. So, so make sure you look out for a WBC on your diabetics, and don't be fooled. If it's normal, look at the patient, okay, and assess them clinically. So these are some of the x-ray results. So first thing, we wanted to make sure the patient did not have any gas gangrene, and there's no bubbles in the soft tissue that we can see. We do see some evidence of post-surgical amputation here. I'm going to show you a better picture of the toes, which we were significantly concerned about. But on this view, unfortunately, I'm not able to zoom, but you can appreciate some calcified arteries on the posterior aspects of the leg here, which screams to us that we need to make sure we've got some vascular on board. He did bleed, as you can see from the previous picture. So, I was very happy that there was lots of bleeding with our INDs. So initially, I think that if we get the right management on him, he'll be able to heal. And this photo is a zoom photo of the remaining toes, and you can see the massive destruction as the remaining second and third metatarsal heads and proximal phalanxes. Massive destruction. Even some along the remaining metatarsals of his fourth and fifth toes. So he obviously has osteomyelitis. So what we want to do is make sure we put him on some IV antibiotics or PO antibiotics that have really good bioavailability. We did a bone biopsy at his second visit after we received these results. So this is our second visit with him. So our plan is to, we made sure that we were going to flush daily. This is another of our students. And this is the way that we flush. We use a large syringe with tea-colored saline betadine mix, and we just slowly flush. You can't appreciate by this picture, but the foot was significantly less swollen, significantly less red, and significantly less malodorous. We put him on PO antibiotics, and we chose a ciproflagyl combination that's going to have both gram-negative, gram-positive, and aerobic coverage. But he really does need some IV antibiotics. But when I prescribe IV antibiotics, when that happens, we have to make sure his vascular status is on point, because if it's not, the antibiotics are not going to get to where they need to go. So that has to happen really, 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 really rapidly to make sure his blood flow is what's supposed to be. Next, we're going to make sure he has consistent, correct wound care management. We're going to make sure if he's locally, he sees the wound care nurses at South Beach. And he honestly needs a TMA. I mean, those toes are not viable any longer. So he definitely needs a TMA, maybe some revision along those metatarsal heads so that he can have a functional and stable foot. All right, I went over, but are there any questions?
First of all, congratulations, Dr. Hill. I mean, a wonderful presentation. It sensitizes us to the situation in a country like the Bahamas, where we have people dispersed across many islands, and the need for a kind of protocol, a unified approach. And this multidisciplinary idea is the way to do it. Can you give us your thoughts on how we can institute this in a seamless and integrated manner? Thank you.
So I think the first thing that we need to do, so when I go into a location, I find out who's around me. So who are my primary care doctors? Who are treating the patients in the area? And I make sure I know them, and I make sure they know me. I go to their lectures, they go into my lectures. So I make sure that those primary care doctors, those ARMPs, those folks that are treating my diabetic patients, we have a good relationship so that they know that those consultations are happening. Bahamas is small enough so that you all should know who's who and who is treating these diabetic patients. You guys should have these phone numbers of PCPs, ARMPs, the folks that are treating your diabetics on tap. You should know them, number one. Number two, you should have a knowledge of those specialists, the vascular surgeons in your area. I think Dr. Farquharson is here in the Bahamas in terms of vascular. You need to have his cell phone number. You need to make sure that you know him, just so that when you're consulting these patients, like this gentleman needs to see Dr. Farquharson or a vascular over in Eleuthera, or just something to make sure that his vascular status is ready to go. the nursing staff is integral, because these are the folks that are going to be able to see him daily. So they have to be educated, they have to be trained. You know, his wounds actually worsened because of the type of wound care that he was receiving was inappropriate. So we have to make sure that they're trained. So constant CMEs, but not just these virtual ones, practical CMEs, having some, you know, maybe bring some over, maybe practice some wound care dressings, and make sure that they're not too tight, to make sure that they know how to do a compressive dressing, a betadine wet to dry. You guys, you have great nurses at South Beach, and they can be doing some in-services for the nurses to teach them how to do some wound care. But I think knowledge of the folks in your area is going to be your first steps. And maybe over time, you all can get, you know, a conglomerate of, you know, this is, you know, the patient goes from him to you know, to the podiatrist, to the vascular surgeon, to the wound care nurse, so that it's, you know, there's already kind of a, we call her first, we call him next, you know, kind of a way to go.
Thank you very much. Brilliant. Thank you.
Yes, thank you, Dr. Hill. Very good, excellent. Are there any other questions before we move on to our next presentation? Very interesting case study. Go ahead, Dr. Horsley. Just unmute yourself and ask the question. Unmute.
Thank you, host. Yeah, I'm
Okay.
unmuted.
Go
What I
ahead.
have found over the years as a doctor, hello, Dr. Hill. Thank you for what you're doing. Appreciate it as usual. Second time, third time is a charm for sure. That surgical shoe that people will stay in for 43 years or longer, it turns out to be a reverse offloading situation. So is there some other way we can get something like a foot defender, or for these high-risk patients, what do we do? Or do we get quarter-inch felt pad and modify the inside of a surgical shoe that the person's been wearing for literally a year or two or three or four or five? What about damage from the surgical shoe that could be actually iatrogenic if we don't recognize the offloading potential of a modified shoe?
This is a question for me, Dr. Horsley.
I don't know. A question for everybody. What do we do about surgical shoe damage? We know I've used millions of them and they're great. But what happens in a situation where the patient can't afford it? So and maybe it's not a question. I just wanted to point out the fact that the surgical shoes actually look like they're causing damage that I have prescribed over the years. And then what I've done is the quarter-inch felt and try to do some offloading. And it has been very beneficial right up to the new foot defender shoe that one of the creators from Nike has designed. It's supposed to be so great. I haven't tried it yet. So your thoughts on offloading and damage from a surgical shoe?
Oh, I definitely agree with you, Dr. Horsley. That's there's little to no evidence that surgical shoes help treat neuropathic or diabetic ulcers. The foot defender is formatted in a way or constructed in a way similar to a total contact cast. And so as we know, as I'm sure you know, probably has the best evidence in regards to managing the diabetic foot or neuropathic ulcers. So treating with resolution around 6 to 7 weeks, as opposed to a surgical shoe, as we see in the community, patients with surgical shoes wearing them for excess of 4 or 5 months in an attempt to try to heal or offload an ulcers. And so, I mean, the shoe itself is no different than, I think the shoe is more so to accommodate a bandage, but it does nothing for offloading. I agree also the point that you made, and that's something I've done over the last just a few years, gone to more the felt offloading pads, because many of these patients, either if they're at advanced age and cannot tolerate a walking boot or removable boot or total contact cast, and to prevent them from doing things like removing their surgical shoe by applying that quarter-inch felt or half-inch felt to the foot, even when they remove the surgical shoe, you at least you know that there's something on the foot that's continually that's maintained to offload that pressure point. So that's something I've gone to, and I agree with you that we have to maybe utilize these devices, utilize these kind of products in this population.
Thank you, Dr. Cuffey. Plus, I buy the roll 1/4-inch felt pad, comes in a roll, and I will actually make an insole so we don't always have to attach it to the foot. But I really thank you for your input. And
that's a good. I mean, I've done that. That's where I started. But I know sometimes you place that in a surgical shoe and they go home and they take it off. So it's only as good as right. It's only as good as they're using it, right? So it's like the only time you see that surgical shoe is when they come to your office. You know, that's it. When they get the minute they hit the house, that thing is off and they're walking around to the bathroom.
All right, we need to put a little bear cam on the shoe so we can document its usage or sensor.
Yeah. Awesome. It's similar to the diabetic shoes. So they wear them, they're brand new every time they come to the office because they never wear them any other time. All right, thank you very much for those questions, Dr. Horsley, Dr. Johnson, very good. We're going to move on to our next presentation. Dr. Cherison Cuffey is Associate Professor at Barry University School of Podiatric Medicine. He is one of the lead researchers at Barry University and has been doing many studies to not only evaluate products that are on the market, but successful strategies for management of the diabetic foot. So he's going to give us a presentation this morning on research as it relates to the diabetic foot and how important it is, even in a clinical practice, to do research and so that you understand more what's going on with your patients and being able to assist. So Dr. Cuffey, help me welcome Dr. Cuffey. Thank you.
All right. If I can share my screen. I know we're having some technical difficulties earlier. Pull this off. All right.
Up on the back, yeah. I thought it was yours. Okay. Thank you.
Can you see my screen? Are we good?
Yes, we can see your screen. Go ahead.
All right.
Very good.
All right. Great. Thank you very much for being here. I mean, I could never imagine a better backdrop or audience than the ocean. It's unbelievable. I'm pretty sure that if I had a photo of this, I know Dr. Becker's probably taking a photo, that my colleagues back in the States would be envious. The Bahamas, I'm an island boy myself from the island of Dominica. And so I feel at home. This is honestly my dream. And I've been talking about this dream, like here, sitting here in front of the ocean since I was in residency. So thank you very much for having us, Dr. Hill, for setting this up, Dr. Mitchell, Dr. Johnson, and so many of the colleagues that have welcomed us to the island. So in talking about the diabetic foot, I want to mention Barry University. I'm there. I work for Barry University, assistant professor, as Dr. Mitchell mentioned. I've been there for about a decade. Before that, I was in private practice. I graduated from the University of Miami and went on to Temple University for School of Podiatric Medicine. And because it was too cold in Philadelphia, I decided to come back to the South because I'm an island boy and I can't handle the cold weather. This is my team, or the team I work with. Dr. Snyder is at the top, the director of the program, the limb salvage program, essentially the clinical research program at the Barry University. I'm probably the lead sub-investigator and some of the principal investigator for a few studies. And we have several doctors, my wife, Dr. Sharon Cuffey, Howard Pedasevsky, Dr. Brill, and my two wonderful nurses here, Maria Schwartz and Chanel Jean-Baptiste, also from the island of Dominica. So we've done a lot of studies. I don't want to get into that so much because I know we're short on time. Maybe when I get back to the States, when I have to present this, I'll present this to the students in class. But we've done 50 diabetic foot ulcer studies so far over the last several years, with thousands of patients being treated for this exact issue, that case study that was presented by Dr. Hill. Now, I won't go into diabetes in America, but we know it's significant. But let's be specific about what's going on here. In the Bahamas, as you know, in 2005, communicable disease prevalence study was shown that 6.7% of the local population, about 23,000 people, were diagnosed with prediabetes, certainly 32,000 had diabetes. The IDF in 2005 showed that there was, 2014 showed that there was 34,900 people here with diabetes. And certainly that number has increased over the years, considering epidemic status in 2005 with 13% prevalence. I just researched this, looked at the number recently at the IDF in 2021, said it was 8.8% from ages 20 to 79. I'm not sure what that means, if the numbers are going down or going up, but from what I can tell, it's certainly still an issue, not just in America, but certainly here in the Bahamas. Dr. Dwayne Sands, the Minister of Health, just a few years ago, in the Bahama Journal, was mentioning the importance of what we're talking about here right now, the importance of preventing foot ulcers. He also eloquently stated that it's been shown that establishing and maintaining a multidisciplinary foot care team. So he stated this in 2018, that a multidisciplinary foot care team can be associated with a drop in the number of diabetes-related amputations. And so, as I quote, he quoted Dr. Sands, so the podiatric medical care team is a vital and increasingly valued addition to the multidisciplinary team. So this is the Minister of Health, his words, not my words. I believe he understands the importance of that. And certainly what we're talking about here today is going to be increasingly important in managing this population. According to the IDF, by 2030, the number of people with diabetes globally will rise to an estimated 552 million. That's significant for us, not just podiatrists, but all of those of us who manage the internal medicine care team, cardiovascular surgeons, orthopedic surgeons, nephrologists. That's significant. All right. This is a foot. This is a foot I did surgery on. As you can see, there's no toes. We did a transmetatarsal amputation, same amputation that patient in the case study is probably facing in a few, if not a few days, a few weeks from now. 50% of these patients, of course, at risk for developing a foot ulcer, 85% for lower these foot ulcers result in amputations. All right. And as Dr. Donshin said, it's a marker for death, right? A marker for death. So the neuropathic ulcer, 45% 5-year mortality rate, greater than that of prostate cancer and breast cancer. I know in the States, we talk a lot about breast cancer. We make a big deal about prostate cancer. But the neuropathic ulcer, that ulcer on the bottom of the foot, that patient that presented with the case study with the neuropathic ulcer, in 5 years, his mortality rate within 5 years is 45%. All right. And now if he has the presence of peripheral arterial disease, right, you see later on right here in the ischemic ulcer. So ischemic ulcer is that same patient potentially with peripheral arterial disease we saw in the calcifications on X-ray. His 5-year mortality rate is 55%. Okay, and PAD 64%. So these are numbers that we can't ignore. All right, these patients, when they come to our office, they're smiling, they're happy, they have families, but in 5 years, that person may be off this earth, and gone to see the Father. And so these are the people we're trying to protect and trying to keep them around. There is a stairway to amputation, and for us researchers, this is what we're focused on, right? Trying to preserve life, trying to preserve these feet, because we understand that if you lose your foot, the result is catastrophic. In a few years, within 2 years, you're likely to lose the other. And then within 5 years, you may be dead. All right. And that's significant. And why is that significant? Not just for preservation of a life, but these companies are making millions of dollars and trying to, or investing millions of dollars into this industry, because they recognize that there's patients and this number of these numbers are dramatically increasing over the next few years. So it's not just that they're looking to help, but they're also looking to monetize and capitalize on this population. All right. And so we need to utilize these companies to help our people. All right. We all know about the cardiovascular disease in diabetic patients, and that's and it's significant. And that's where we have this multidisciplinary approach to the importance of primary care, evaluating other systems such as the kidneys, the heart, the liver, the brain, the mind, all these cognitive areas that complicate managing these patients and also require other interventions in the hospital system. These hospital systems in America, they love us, right? Why? Because we request X-rays, we request MRIs, we consult vascular teams, we consult the infectious disease, they consult the orthopedists, the orthosists, and makes them, generates income for them in some ways. But certainly in certain situations where you have government organized health, that may be a significant cost to the system, and I certainly can understand where that could become a problem. All right. Childhood obesity, something is significant for us. Looking at children is who, eating too much, poor diets, and 70% of these obese adults, adolescents become obese adults. The numbers are here. Prevalence of childhood obesity increased from 4.2% in 1990 to 6.7%. And so that's significant for us. And these are the things that we have to start to modify and really look at closely when we talk about research and managing the diabetic foot. Because if we don't start here with the children, there's no way that we can expect that when they become adults that they're going to just now develop good habits. So if you can develop good habits early, we can definitely have a better chance of preventing these issues down the road. Now, risk factors, as Dr. Hill mentioned, prior amputations, foot ulcer history, neuropathy, foot deformity, arterial disease. And Dr. Horsley mentioned it right there. The diabetic foot, these patients have no feeling. They're insensate. They're coming to your office with a foot ulcer, open wound, a gaping wound on the plantar foot. You can pretty much stick a probe, a cotton tip applicator from the bottom of the foot to the top of the foot, and they walked in with a surgical shoe. All right, they walked into your office with a surgical shoe. They have no idea, and because they have no idea, there's no pain, there's no feedback mechanism to tell them that this hurts. They continue to walk and they continue to damage that foot, and of course, that's what ends up getting infected, and the ischemic factors contribute to the disease process and results in amputation. All right. Now, it was interesting that when I came to the clinic, there was so many documentation, so many good information in regards to risk stratification already present. So the bones are here in the Bahamas. The bones are here, and you have a small group right now. And so, unlike in the States where there's so many doctors, there's so many people that are doing their own thing and not following specific guidelines. And so there's a confluence of just misguided treatment in the States. Whereas here, right now, you have a really small group that as you bring other doctors in and as you start to expand, and if you follow these guidelines, you follow these protocols, will really benefit the diabetic population. All right, but I want to get more specifically into the research aspect because I know we're short on time. But these are some of the photos that we deal with on a daily basis. Patients with infections and foot ulcers, and complications that are very scary. And certainly all these photos are pictures of mine that I've seen in the hospital, I've done surgery on, and were able to salvage their feet in many cases. All right. So let's get into, let me see. So some of the offloading. Well, this is what I was going to mention as far as the offloading. Key to everything, right? You have to keep people off their feet, the defender, the foot defender, total contact cast. These are essential parts of this diabetic program. No evidence right now with these surgical shoes and offloading heel relief shoes. All right, total contact cast, rate of healing 90% within 6 to 8 weeks. So this is something that we have to be really focused on, I think, as part of the multidisciplinary team, is getting these patients away from the surgical shoe, but into casts, foot defenders, and figuring out ways that we can get these devices into the hands of the practitioners here in the Bahamas. So going into some of the specific products that we studied back in the States, if you look at some of the most recent studies, a few years ago, Dr. Lavery, Dr. Snyder, several other physicians, they look at the 4-week mark, all right? So typically, when we implement standard of care treatment for diabetic patients, neuropathic ulcers, and if you don't see at least a 50% decrease in the area reduction within those 4 weeks, it's likely or unlikely that patient will be healed within 12 weeks. All right. Even with that, about only in the study, and this is several hundred patients, only about 58% of those patients by the week 8 mark actually improved or resolved their ulceration. So that was significant. So even in spite of utilizing standard of care treatment, not many of these patients with diabetic ulcers heal. And so in many cases we have, because of the faulty mechanics or faulty, metabolism in the foot, because you have cellular dysfunction and other factors that contribute to non-healing, we find that you may have to utilize adjunctive treatment options to resolve these ulcerations. So we've done a lot of research into some products that we're utilizing now for diabetic ulcers. Apigraph is one of them, the bilayered human skin equivalent, bovine type 1 collagen with fibroblasts and keratinocytes that can be applied to ulceration that's non-healing. We have products like the Cellutome, so similar to a skin graft that you would procure from the leg or from the thigh in a traumatic injury or for covering a large a defect. This device utilizes blisters, so epidermal blisters. Essentially epidermis autologous epidermal blister graft. So you apply it to the thigh. It heats up the skin. You then procure these epidermal cells that can then apply to the ulceration, similar to a split thickness skin graft. We have Dermagraft. It's a human-derived fibroblast product that can be applied to a wound. It's cryopreserved. That might be an issue sometimes with delivery, but certainly another option that we've used in the past and have seen some incredible results, not just in clinical practice, but has been exhibited to show a significant improvement in the treatment of diabetic ulcers in research, in clinical research. Something newer that we're doing presently right now in our clinics, this Skin TE. We did this study about maybe 3 years ago, and now they've because of the really excellent results that they've seen in this in the preliminary use of this product, they've kind of expanded this product to deeper, much more full, not just full thickness ulcerations, but ulcerations that it potentially extend to bone, capsule, muscle, the fascia. And so that's what they're looking for, to see whether this Skin TE, which is a human cellular and tissue derived product, we obtain a ellipse of skin from the medial calf or the thigh. We send it to their lab, which is then they use a proprietary process to develop this kind of oatmeal looking like full thickness graft that's applied to the ulceration. And I've seen some good results so far with this product. It's still in the stages of FDA approval, but it can be, for deeper ulcers, but it can be utilized right now for diabetic ulcers in the general population, certainly in the States. Dermapaste, another product that we've utilized, it uses pulsed acoustic cellular expression technology, proprietary, just so essentially utilizing ultrasound, these shock waves into the tissue to enhance or decrease bacteria burden, decrease inflammation, and hopefully improve local perfusion to the tissue and enhance and wound healing. So great product, another option, and something that we've studied back in our office. Now, this is probably one of the hardest products I've seen, or hardest clinical trials I've done to date. This one is a tough one because it's gene therapy, right? We are utilizing a hepatocyte growth factor plasmid that is meant for angiogenic, meant to improve or treat patients with critical limb ischemia and a non-healing wound. And so we saw in that slide where neuropathic ulcer has a 45% mortality rate, but these patients with peripheral arterial disease is near 64% 5-year mortality rate. And so very narrow spectrum for this study. We're looking at patients who have significant arterial disease, essentially stage 2 ischemia, but has not gone on to gangrene of the foot. So possibly even that patient, that case study that Dr. Hill presented, would be a candidate for this type of therapy. we would we obtained this it's a right now it's in randomized trial, so I'm not sure what the patients are getting, but this hepatocyte growth factor is injected at 8 sites along the blood vessels within 1 centimeter of the main the tibial peroneal arteries in the leg and sometimes in the foot based on MRA or CTA of the lower extremity. This is a wonderful, it looks like it certainly so far has shown some significant results in the preliminary stages, and hopefully maybe in a few years, maybe a significant option to treat our diabetic patients and patients with significant arterial disease and improving their circulation without surgery. Moleculite, probably a device that would have been would have been a wonderful product to use on that patient in the case study, where you can actually see the bacterial fluoresce on the skin through just, you dim the lights and as you can see in this photo to the right, this isocyanine looks like that patient has a lot of pseudomonas here on the local skin. And so you'll be able to visualize the bacteria, measure the wounds, and hopefully as you treat that patient, can see right there in the office the clinical improvement without objectively, without actually making subjective remarks in regards to the resolution of that infection. All right. And so I try to keep it short. And so, I'll leave it with that. I know we started with a prayer, and in Hosea 4:6 says, "My people are destroyed from the lack of knowledge." I think if we continue to improve our knowledge base and continue to research these many products, and here in the Bahamas, I know you have a large population with some unmet needs, and I can't say enough how I believe that this if we can get something going, and I know Dr. Johnson is trying to work, and Dr. Mitchell is working hard in trying to develop a diabetic foot team with wound care nurses, connections with primary care and vascular surgeons, orthopedists, orthotists, infectious disease specialists, because that's the core. That's when I walk into a hospital, that's the core group that I'm working with on a daily basis to save these feet. It's one thing to see a picture. It's another thing when that picture is your patient, is your mother, your father, your brother, or sister. All right. So my grandmother several years ago, right there in Miami, the same hospital I work at now, she lost her foot, and within 2 weeks, within a month, she died. And so it's significantly personal to me. And I certainly hope that it's personal to you, and we'll hopefully make the necessary changes to improve the state of affairs, not just here, but for my local area in the States. All right. Thank you very much.
Thank you very much, Dr. Cuffey. We have one question I would like to ask before you leave. And we have a lot of medical students and residents on the call. And so I'm sure they're thinking, and the question that we have is, how do you begin? You have a lot of research. I see that you've done a lot of research, a lot of industry related and a lot of high level research. But as a medical student and as a resident, sometimes they have to do research as a part and as a clinician. How do you begin in where you are to do some research to be able to get some information to be able to help with treating your patient? What would you recommend?
Well, many of these researchers, these big names that you see, they had to start us somewhere, right? And so a lot of times it's just, if you have an area of interest, an area that you're concerned about, you start to simply do things like write about it, right? Maybe write about, present, you have a local journal, present the case for diabetes and the importance of multidisciplinary research, and you submit it, and you have them, and have it posted, right? And after that, if you have really more, if you're working in a hospital setting, you're working with a doctor that who has a large population of these patients. So certainly you have 3 clinics that we've already gone to. We've gone to several other clinics in Abaco. A large population of diabetics there. I can't imagine. I mean, there's so many opportunities with that population just by you walking into that clinic. You just talking to the to the headmaster or the administrator there, to allow you access to maybe some of the charts, and without taking away identifiers. And you're looking at how many patients a month are coming in with diabetes, how many patients a month are coming with foot ulcers, how long, and then and even simply as how long those ulcers are taking to heal, and just that information could be significant enough to change, to help determine where interventions can be applied. And just when you do these things, so you do it for Abaco. That's one article right there by itself. You do it for NASA. That's another article. And so when you build up a portfolio, now you're getting into the research team, right? You get into the research arena, and certainly when you present these portfolios to a bigger company like 3M or Smith and Nephew, and then you say, and they realize that, okay, wait a minute, there's a large population of diabetics here. There's a lot, that we can probably utilize to these products that are already, certainly already available on the market, but they're looking to see how it affects, how it can help this population. They will subsidize that research for that product in your clinic, as long as you have the facilities and you can show that you can produce or manage those patients for a period of time. And they will give you, I'm telling you, these companies will, I don't want to get into the numbers, but they can give you significant dollars as long as, it's well organized, and you can show that there is a met need, there's a need, and you can meet that need if you have that product available.
Awesome. All right. Thank you very much. And can you stop sharing so I can share the last slide? No problem. Okay, so as we conclude today, I'm just gonna show a slide. Hold on one sec. Okay, I want to share this slide with us as we conclude. Just to review some of the concepts that we covered today about the multidisciplinary team. So the multidisciplinary team is a group of health professionals who work together to improve the health and the treatment of individual patients within our system. So these persons can be working in one organization, let's say, for example, at Princess Margaret Hospital, or it can be in different organizations like Department of Public Health, Ministry of Health, could be PHA, could be a number of organizations working together, Doctors Hospital. But around the area, the idea of the diabetic foot, the multidisciplinary team, research has been done, and it's been shown to be highly effective when applied to the diabetic foot prevention. The heterogeneity, or the different types of teams that we see, and also the interventions, can actually be a benefit to us. So as we have been talking about these multidisciplinary teams today, we know that we may not have everybody on all our teams, but we definitely can start with who we have. So we've seen that the research has shown that working in teams can actually reduce ulcerations and lower extremity amputations. And podiatrists on a lot of these teams have been suggested as the gatekeeper for these teams. And so we definitely here in the Bahamas, one of our strategies or our desire is to see a multidisciplinary team in a formal way. I know a lot of us work informally with primary care doctors as well as vascular and everybody else. But we would like to see this formalized so that all persons who are working in this area will have access to this team or these persons on the team. As podiatrists, we are always available to assist and to provide expertise. And so we're inviting persons, if you need podiatrist, you need to refer a patient, you just need to have a second air, just feel free to call any one of us, myself, Dr. Johnson, Dr. Horsley, any of us. Will be very happy to assist in any way. I just want to bring to your attention as we close, in the chat, Remember the link for sunshinelearner.com, and then the keyword is life learner. Remember, if you want to get your CMEs, please remember to go to that website and give your feedback about the seminar this morning, and then also fill out so that you can get your CMEs this morning. If we have no other questions, then we're gonna end, so we're not too far behind. If you have any questions, you can go ahead and unmute yourself and ask your question. Go ahead.
Good morning, Dr. Black here, and perfectly on time team. I am not sure that everyone actually has the ability to unmute. So if you have a
Okay.
question, you can also
Raise
place
your
it in the
hand.
chat.
Okay, beautiful.
I have a quick question, if I may,
Go
Dr.
ahead.
Mitchell.
Go ahead, Dr.
Dr.
Huxley.
Dr. Cuffey and mentioned, and Dr. Londono mentioned about fall risks. I wonder how high the percentages of fall risks that is present, and do those like orthologic or any of those special braces that secure the ankle with a AFO to the foot, do they work? Has anyone had success with them? And is anyone acknowledging the fall risk problem?
Yeah, for me, fall risk is significant. I can't give you numbers in regards to what that is, as far as, but it's something I certainly evaluate with each patient, right? Older patients or even younger patients with instability at the level of the ankle or the knee or hip. You're not going to place them or immobilize them per se in a total contact cast or a walking boot. Now, if I feel like it's necessary, I may add things like a walker or AFO if there's some significant, some other deformity like a drop foot that may be contributing to the risk of falling. So many times it requires that's a comprehensive evaluation of musculoskeletal, lower extremity musculoskeletal presentation to determine that risk and what interventions may be necessary to mitigate that risk. In some cases, you may just have to place a patient in a wheelchair. Now, not all patients have their homes can accommodate a wheelchair, and those are issues that I've dealt with. Certainly, some homes have don't have or they're in an apartment with no elevator access, right? So they can't go up; they have to go upstairs. And so, if you put them in a walking boot or some type of device like that, you increase their fall risk. So these are things that I agree to your point that this is something we definitely have to look at on an individual basis, and you make decisions or interventions necessary based upon that.
All right, thank you.
So we have one comment in the chat that says, these patients, those are at risk for fall risk, great candidates for physical therapy. Our physical therapist, Dr. Adderley, therapeutic exercises while offloading can improve perfusion and wound healing as well. So that's a suggestion she's recommending as well.
I'm
Definitely.
glad I'm glad she put that in the chat, because physical therapy is also one of the multidisciplinary partners that need to be consulted post-operatively, post-amputation, post-wound, all of the above. So 100% we need physical therapy on board.
Go ahead, Dr. Adderley.
Thank you so much. I'm glad that I saw this. I came in very much in the beginning, so I'm so grateful for the presentation. And there was a lot of talk of multidisciplinary team approach. So I didn't hear physical therapy before, and I wanted to make sure and put the plug in for this, because physical activity is very, very important, one, for controlling the diabetes presentation in these patients. And definitely when we talk about quality of life and quantity of life after these interventions, good physical therapy can definitely put a dent in it. I know we're still doing a lot of studies on it, but I just wanted to make sure I put the plug in for physiotherapy for these patients. Thank you so much. I enjoyed your presentations.
I have a therapist that I send pretty much most of my patients to, but it's critical. It's not like I know we didn't mention it, but physical therapy is critical to this whole process. after we do surgery on these patients, the first person to see them after the surgery is a physical therapist.
Yes.
And so to make sure to see whether they can manage being off their foot. If they can't, then they can't navigate stairs or navigate their home because there's 2 steps to get in the house, and occupational issues. I mean, those is very critical. I mean, I'll even add nutritionists. I know a lot of medical doctors are so focused on the medical part, but nutrition and holistic options to treat these conditions are critical to the disciplinary team. But these are all things that we have to kind of add, and we have to make, it is best if we can get them in early, but they're all critical to the whole the team approach.
Awesome. All right. Well, thank you very much for attending our session this morning. And we definitely heard that the multidisciplinary team approach is critical to the successful management of the diabetic foot. And so we want to continue, and we want to encourage all of you, especially as primary care physicians and other specialists, that we need to work together to make sure that our patients are getting the best outcome. We see that having a diabetic foot ulcer or getting an amputation is not just that. It is directly related to their mortality and actually their life, how long they're actually going to live. And so when we see a wound or we see an infection, that should alert us to want to do as much as we can to help that patient as soon as possible. And definitely using a multidisciplinary approach is the best way to go. So thank you, Dr. Black, for having us. And thank you, everybody, for attending. Have a wonderful day. And we're very happy to assist in any way possible. Thank you.
Thank you very much, Dr. Mitchell, and thank you very much to your team. Thank you very much to the speakers, Dr. Hill, Dr. Cuffey, Dr. Johnson. What I'm going to ask you to do, Dr. Mitchell, is if you could just put together a little flyer for us with the key points and the key contacts, including for Dr. Hill and Dr. Cuffey, and we can circulate that and also put it on the CME website so that everyone has access to it. I see someone says in the chat, awesome, congrats. And that really, really sums up the meeting. Thank you very much for presenting to us with the team.
All right.
Before we end today, though, I just want to say what really struck out at me were some of the things that were said. And what I want to remind the audience is that the Bahamas has the largest rate per capita of diabetic foot injuries in the world. And this is avoidable. And so hopefully working together with your team, we can take this rate down. So I want to congratulate the team again. And I also just want to highlight about the CME. There are no promises for CME. We are trying our best to work within the guidelines of the Medical Council. And so as soon as CMEs become available, we will let you know, but do the feedback, because once you've done the feedback and we get the approval, you will get your CME. And just to remind the audience, I had made some slides, but I think I don't have it here to share with you guys. But we do have 2 meetings coming up. Our first meeting is next week on March 15th at 8 a.m. and the PMH Pharmacy will be sharing their perspectives with us. And then on March 29th at 9:30 p.m., we have PAHO, who will be presenting One Health Approach to Antimicrobial Resistance, a webinar for human, environmental, and agricultural health professionals. CME is in the works for this one. We need you to pre-register for this one, so we will start sending out the link shortly. Thank you very much, everyone, for participating. Everyone have a good day.